All right, everyone. Well, welcome. I think we have people joining us now. Welcome to our Advances in Total Joint Replacement webinar. My name is Trey Dobson. I'm the Chief Medical Officer with Dartmouth-Hitchcock at Southwestern Vermont Medical Center. And we have several orthopedic surgeons and an occupational therapist here today to talk to you about joint replacement and the advances that we've seen in the last decade or so, as well as answer your questions. So let me do this. Let me go ahead and introduce our panelists. The first is Dr. Suk Nam Kuhn. You have their bios. You have a link to their bios. I'm not going to read their everything, but I will just highlight a few things. Dr. Nam Kuhn attended Princeton University for undergrad and then received his medical degree at the New York University School of Medicine. He did residency in orthopedic surgeon at Stony Brook University Hospital in orthopedics. And he received fellowship training in sports medicine at New York Hospital for Joint Diseases. He is board certified orthopedic surgeon. Also on the panelists today is Dr. Michaela Schneiderbauer. She earned her medical degree at Ludwig Maximilians University in Munich, Germany, and at Harvard Medical School. She did her residency training at Basel University Hospital in Switzerland, and then fellowships in joint replacement surgery and orthopedic oncology at the Department of Orthopedics at the University of Miami Jackson Memorial Hospital in Florida. Mick St. Jakes received her undergraduate degree in biology at Massachusetts College of Liberal Arts. She completed her master's in occupational therapy from the Sages College in New York and is a member of several organizations, including the National Board of Certified Occupational Therapists, the American Occupational Therapy Association, and the American Society of Hand Therapists. So thank you again to our panelists. We also have Dr. Matthew Nofziger scheduled. He may be delayed in the operating room or seeing patients, but I'll go ahead and introduce Dr. Nofziger and hope that he can join us. Many of you know Dr. Nofziger has been here for over 15 years. He received his undergraduate education at Goshen College in Indiana and his medical degree from Indiana University School of Medicine, completed a residency at Fort Wayne Medical Center and a fellowship at the Nerschel Orthopedic Clinic in Virginia. He is also certified, as all of our physicians, board certified by the American Board of Orthopedic Surgery. So I believe at this point, I'm going to be turning it over to Dr. Schneiderbauer to kick us off.
Hello and welcome everybody, and thank you for joining. If we can advance it to the first slide. This webinar today is intended to give people information about the advances in joint arthroplasty, as well as the projects that we have started at Southwestern Vermont Medical Center. We want to go through a couple of slides and then hope that you have some questions that we are happy to answer through the Q&A tab that you can find in the Zoom at the bottom usually. So please feel free to ask us any question you have and we'll try to answer them. So when should you consider joint replacement surgery? It's usually starting with a little nagging pain, and people try relatively simple methods first, including heat and ice, maybe some rest, maybe trying to walk it off or attempt some weight loss, especially for knee pain. That can help significantly, as well as over-the-counter pain medication and topical analgesics. And that is a totally legitimate first step to try to control the discomfort that you have with beginning arthritis in your joints. Next slide, please.
So after you've done some of the simpler measures, there are more aggressive measures that as a doctor we may suggest. Physical therapy to try to strengthen the muscles around the knee joints or hip joints, or whatever arthritic joint, as well as trying to increase the range of motion. Cortisone injections and hyaluronic injections are available to try to ease the pain of arthritis. PRP is a newer type of injection. It's a little controversial how effective it really is, but it is something that our office offers with Dr. Gutman. Sometimes a minor surgery may be something to consider before joint replacement, arthroscopy to sort of remove loose cartilage that may be flapping and flaking and can be pain generators, can often have some benefit. And something that has been shown in patient-reported outcomes is improving your own mental health. When a patient comes in with amounts of depression, it is much harder for them to recover and their outcomes are much less. And so, talking with your primary care about trying to improve your own mental health can have a great benefit. Next slide.
Since Dr. Nofziger is still busy, we'll probably cover some of his slides. And this is going into the history of total joint replacements. This is really not a new procedure. It has been tried around 1890s, but then really has been popularized by Dr. Sir John Jarley in the UK, who made hip replacements very successful and an established procedure. Next slide. It's joint replacements are really one of the most common procedures in the US in terms of surgeries. There are over 1 million joint replacements performed in the United States, and at SVMC we do hundreds of them a year. Next slide.
Before surgery, we do have the patients attend a joint replacement class. These are currently held in small groups or online. One of the great advances I've seen in patient recovery is with patient education. When patients are more aware of what to expect during surgery and right after surgery, they improve better. Other things to try to do before surgery is to stay fit and active. When the body starts to decompensate and when your muscles have weakened and your motion has decreased, it is much harder to recover. When your muscles are strong and limber, it is a much easier recovery from any surgery, but certainly joint replacement surgery. And something we do require before surgery is getting clearance from your primary care doctor, mainly to make sure that you're at your peak health, and importantly, that your blood sugars are at an optimal level to minimize risk of infection and, again, give you your best outcomes. And we also require a dental clearance. We want to make sure if there are any cavities or dental work that needs to be done, that's done before we put implants in and not afterwards. Next slide.
So some of the things that we cover in that joint replacement class is how to be successful before your surgery. Like Dr. Namkoon was saying, we want you to be prepared going in so that when we send you home, you have everything you need. We go over in the class kind of how to prepare your home after surgery. That includes removing any fall risks from your house, installing any grab bars, or just setting you up for success once you do return there. We talk a little bit about preparing your food and stocking your fridge, any equipment that you might need after surgery. And then we also kind of give you some advice on some medications that you might want to stock at your house for after surgery so that you don't get home and think, oh, I wish I had Tylenol or ibuprofen. We want you to have all of that stuff before surgery so that once you're there and at home, you can kind of rest and get that situation all set up for yourself. Next slide.
I think
so. With implants, technology, just like with anything, has been increasing exponentially. The implants are more anatomic. They are lasting longer, and we're able to put them in with smaller and smaller incisions. Next slide.
So what are the most recent advances in hip replacement surgery? One of the topics that is discussed quite a bit is the approach of the hip replacement surgery. The two main approaches used are the posterior approach and nowadays also the anterior approach. we have this little slide up to make a little clear the difference between the two approaches and maybe also the similarities in some degree. The position of the patient during surgery is a little different. Most people do the posterior approach with the patients laying on their side during surgery. The anterior approach has you laying on your back. The risk of complication is somewhat similar with both surgeries. Some people report a little more of wound healing issues with the anterior approach, but it's relatively minimal, the difference. The length of hospital stay when the same rapid recovery protocols, meaning, you know, all the best anesthesia pain management is applied, is not that different in terms of the hospital stay. There might be a little shorter recovery time, especially time to not using the walker anymore with the anterior approach because less muscles are disrupted. Next slide, please.
So with the anesthesia that we use, we are typically using more spinal anesthesia and nerve blocks to avoid general anesthesia. This allows us to obtain pain control, but without the sort of grogginess and sort of, you know, general sleepiness that occurs with general anesthesia. And with that, patients are able to get up and stand and walk pretty much a couple hours after the surgery. Whereas with a heavy general anesthetic, they're usually going to be pretty drowsy and sleepy, probably for most of the day, and probably wouldn't be able to get much activity going until the next day. Next slide.
With the pain management around surgery, that's probably one of the areas we have had the biggest and most significant advances over the last few years. We've learned that attacking the pain from multiple different angles allows us to reduce the dose of the individual medications and also allows us to address the pain from different angles. So we do that to avoid giving you too much of one medication. And it also helps us to reduce the necessity of heavy opioid doses. The narcotics or opioid medication certainly has had its good share of bad press, and rightly so. We need it around surgery some, but doing this multimodal pain strategy allows us to reduce the use of that medication to the absolute minimum. Next slide, please. This repeats some of the content of the last slide, but it also goes into the fact that we can use local blocks and injections to fight the pain. We inject the area of the surgery. At the end of surgery, you wouldn't even know about it because you're still, you know, under anesthesia, but we inject locally with substances that help reduce the swelling and tackle the pain right there where it arises. This again allows us to use less of the opioid medication that has its own set of bad effects. A lot of people complain about nausea, constipation, then it has the addiction potential. So to use these other modalities allows us to use less of the opioids. And we encourage all the patients that can take Tylenol and anti-inflammatory medication like ibuprofen, Aleve, Advil to use that medication in the early phase after surgery to try to reduce the opioid intake. You're also encouraged to use ice and elevation. Elevation is actually very important when you have lower extremity injuries, also upper extremity injuries or surgeries. The less swelling you develop, the less pain you're going to have. So we encourage that. We've also recently added modalities like music and meditation to try to help your mind work with the pain and get through the pain with more ease. Next slide, please.
Other things that we focus on, fluid management. Standard protocol before surgery was what we call nothing by mouth before, after midnight the night before. That tended to have people fairly dehydrated on the day of surgery. So what we are trying to do is make sure people really take plenty of fluids before surgery so that after surgery, they're not quite as behind. And with that, they tend not to have as much hypotension, and again, less nausea and grogginess to allow them to recover quickly and get out and active after surgery. Next slide.
We have recently started our same-day joint replacement program. That means for certain patients that qualify to actually have the surgery and go home the same day of the surgery within less than 24 hours. Next slide, please.
Some of the benefits of same-day surgery. Number one, you're not in the hospital. You get to be home where you are ideally at your most comfortable level. And although our hospital has a very low infection rate, there are certainly sick patients in the hospital. And you know, when you're at home, you have probably the lowest rate of infection as opposed to being in the hospital. Next slide.
The same-day joint replacement procedure is not right for every patient. You have to be generally healthy. You have to be able to fulfill certain household tasks by yourself relatively easily. And it is important, at least for the first couple of nights, to have a support person with you that keeps an eye on you. Next slide. We want to make sure that all of you are assured that the advances we have achieved over the last couple of years with joint replacement surgery, they are not only reserved to the patients that are doing the same day process. These advances are applied to all the patients that receive total joint arthroplasties, regardless of how long they stay in the hospital. Next slide.
So the preoperative timeline, usually you call for an appointment. We'll call that week 1. And we should be able to see you within the week to have an office visit and do our consultation. And then if we decide surgery is the best option, in the next following weeks, we try to work, and our office helps prepare, get all these appointments together and clearances, but we get the clearance from your primary care physician as well as your dentist. Typically, the week before surgery, you'll attend a joint replacement class. This way, that information stays fresh. And then you can work on the homework that you're given to try to prepare. And then, typically, if you come in wanting surgery, we'll try to schedule you at about, a 4-week interval to the day of surgery. Again, to get all those preparations in place so that you can do your best. Next slide. And then on a typical surgery day, usually you'll arrive at the hospital anywhere 7 a.m., possibly earlier. You have surgery, usually a couple hours later. Surgery typically will take about 2 hours, and that's where if we're working on getting you out on the same day, physical therapy will start working with you. And in the later afternoon, we can determine whether you're ready for discharge or if you're going to need to stay in the hospital for an overnight stay. Next slide.
So like Dr. Namkoon said, you'll stay for about an overnight or so, and then we're going to send you home. And once you get home, we're going to, encourage you to do some elevation to help control your pain. We'll talk to you about the functional activities when you discharge home. We're big believers that taking care of yourself after surgery is your biggest rehab. So we're going to want to make sure that you can go to the bathroom, that you can shower, you can get dressed, get yourself a light meal. All of those opportunities allow you to get up and move around and exercise with that new new joint replacement. After that, once you're home for a little bit, you'll have a follow-up appointment with your surgeon. And then depending on how that follow-up appointment goes, if you would like to go to physical therapy on an outpatient basis, your orthopedic office will set you up so that you can attend that. Next slide. So, you know, it's really hard to say exactly what your expected recovery would be. It is dependent on what your medical history is, what your activity is going into surgery, and how much effort you put in after your surgery. You know, it's really important that you do get up, walk, and do all of the movement that we encourage you. But in general, you can expect that the first time you stand up in the hospital with us, that it will be with a rolling walker. And you likely will go home with the rolling walker, although occasionally some people do go with crutches. You'll use that walker, you know, immediately and maybe for the first couple of weeks. Then with advice from either your surgeon or your physical therapist, you'll transition to walking with a cane. And then we can start to return to some of our more physical activities that we like to do and possibly return to work. And then you will not be using a walker or cane forever. We'll get you back with just your 2 normal feet, and you'll be walking without an assistive device. And then somewhere around the 8 to 12 week, you know, you should be clear to really start most of your normal activities. Again, led by your surgeon and any therapy that you use. Next slide.